Good afternoon, guys. Please confirm that you can hear me clearly and that you see the title page of the presentation. Hello, guys. Please confirm that you can hear me, that you are hearing me clearly. Please type in yes in the chat.
Ну, мы по шкале видим раз, два, три.
The topic is basic life support cardiopulmonary resuscitation, and we are starting. Basic life support is about how to give proper care of the victim in cardiac arrest. Actually, out of hospital cardiac arrest means cessation of function of heart that happens in field, in out of hospital settings, is considered by the global medical community as a global threat, as a major healthcare problem that is related with very high mortality rate. As you can see here, more than 90% of persons who experience out-of-hospital cardiac arrest die. Statistics from United States and from Western Europe show that more than 700,000 out-of-hospital cardiac arrest cases attended by emergency medical services happen each year. And we should expect that for those countries who are developing, who have low income or lower middle income, the rates of out-of-hospital cardiac arrest as of incidence and the mortality rate is much higher. For example, in China, it is reported that only about 1% of those suffering from out-of-hospital cardiac arrest survive. As you can see from this graph, the likelihood of survival in out-of-hospital cardiac arrest decline very fast. After cardiac arrest, with each minute of delay of life-saving help, the chances for survival decrease mean about by 10% per minute. So if the help is delayed by 5 minutes, there will be 50% decline in survival probability. If it will be 10 minutes or more, there are almost no chances for success of cardiopulmonary resuscitation. And this actually highlights the relevance of early first aid that is to be provided by immediate bystanders of cardiac arrest. Those who are witnessing cardiac arrest should start chest compressions optimally with rescue breathing early and continue resuscitation till arrival of ambulance. If bystander will not commence any CPR but will only call for help for ambulance, on arrival of ambulance, that usually happens 13 minutes or more in Crimea, for example. In some regions, some countries, it is more than 20 or 30 minutes. Clearly, without bystander help, there are no chances for survival and for recovery of out-of-hospital cardiac arrest victim. The principles of providing bystander life-saving help are clearly outlined in the guidelines, international guidelines for cardiopulmonary resuscitation, and the latest guidelines were issued by European Resuscitation Council this year in spring. These guidelines were updated according to the latest clinical and scientific evidence. However, we can say that compared with previous edition of the guidelines from 2015, there are no significant changes as for basic life support cardiopulmonary resuscitation. So everything that was true 5 years ago for principles of CPR, how to give CPR in basic life support, is true for today and for subsequent 5-year period, because next edition of the guidelines will be issued not earlier than in 2025. But absence of any changes is true only for basic life support, for the fundamentals of care, while there is also advanced cardiac life support that is to be provided by medical professionals, and in advanced cardiac life support there are some changes, but this is the topic for our next lecture. On the left side of this slide you can see the simplified presentation of the algorithm of basic life support cardiopulmonary resuscitation. I want to be to tell you from the very beginning, to highlight that basic life support actually is not demanding any specific skills or education. Basic life support is to be successfully provided by anyone who is trained starting from childhood in Western Europe, in the United States of America. For example, BLS is taught in school starting from age of 10 years or even earlier. And it is well known that children from the age of 12 are able to provide effective cardiopulmonary resuscitation. So BLS is the complex of measures intended to support life, and this complex of measures may be successfully implemented by anyone who is having adequate theoretical knowledge and optimally practical skills, trained at least on the mannequin. The main goal of cardiopulmonary resuscitation is to support vital functions. Actually, it is highly improbable that someone will survive cardiac arrest due to the actions of the bystander. Usually bystanders are not getting victims back to life by their own actions. They are supporting oxygenation till arrival of ambulance team. This is what they do. So the chest compressions themselves are actually not able, in most cases, not able to restart a heart. For restarting a heart, there is a need to give more efficient methods like electrical defibrillation, for example, or like Airways, like drug administration and others, which are provided by medical professionals. So the main task for us when we provide basic life support is to support circulation by chest compressions and to support transport of oxygen from atmosphere to lungs, thus delivering oxygen and nutrients to vital organs. On arrival of ambulance team of EMS, the professionals will implement additional actions which will increase the probability of return of spontaneous circulation, of return of normal cardiac activity. Now we are starting to describe the algorithm of cardiopulmonary resuscitation itself, and it actually starts from the safety consideration. Safety is number one. Safety means that when in field you are approaching the victim in a cardiac arrest state, you are to observe environment for any threatening factors, for any dangerous factors. And if there is any threat like fire or smoke or some unstable constructions like in disasters, or maybe traffic or violence from other people, if you see this threat, you are to avoid injury to yourself. You should not become another victim. If possible, you are to stop this dangerous factor, like, for example, to cease fire by using fire extinguisher. If it is possible, but if not, you are to try to remove the victim from this dangerous place to the safe side. And obviously, for doing this effectively and in a safe way, you should ask other bystanders for help. As soon as you will transfer patient to safe area, you will continue with cardiopulmonary resuscitation measures. If in some instance you are unable to remove dangerous factors, to stop them, and simultaneously you are unable to move the victim to the safe side, to safe area, you should not get in the area where immediate threat to your life exists. You should call for rescue services and wait for their arrival. When it is safe, you are to continue with algorithm, and here the step of diagnosis of recognition of cardiac arrest starts. There are 3 simple steps that you should do to check for diagnosis to confirm or exclude cardiac arrest. First thing that you should check for responsiveness. This is done by shaking and shouting. You're gently shaking shoulders of the victim and shouting, "Are you okay?" or something like that. If there is no response from the victim, it means that this victim is unconscious, comatose. There is no need to determine the level of unconsciousness, for example, by using some scale like Glasgow Coma Scale. The diagnosis should be very fast. We should always remember about this graph that I showed you in the beginning of the lecture that depicts how fast the chances for revival of the victim drop when no CPR is provided. So we should start CPR as early as possible. That's why the diagnosis should be as brief as possible, but it should be still reliable. So we are checking for response, and if there is no response, we are moving to the next step. Next step is to open airways. Why we should take care of the airways? It is because in any unconscious person, there is a risk that tongue will block airways on the level of pharynx, like it is shown on the right lower picture. You can see the headed airways, and on the left, blocked airways are shown. When person is comatose due to complete relaxation of skeletal muscles and loss of reflexes, the mandible goes down following the force of gravity, and here tongue and epiglottis may be deviated and may block airways on this level. To remove this collapse of airways, we are to make a simple maneuver that is called head tilt chin lift maneuver. We are putting one hand on the forehead of the victim, and we are using 2 fingers of our second hand to lift up the mandible, to lift the chin. As you can see, when we are implementing this maneuver, the configuration of airways is changing. We are straightening the airways, we can say. The epiglottis goes up, the tongue goes up, and we hope that airways will be open from this moment. While holding the head in extended position and chin lifted, we are now to check for breathing. For doing this, we should put our ear closely to the nose and mouth of the victim and simultaneously look at the chest for chest rising. We can use so-called look, listen, and feel mnemonic. Look for chest rising, for chest movement, listen to the breathing, and try to feel out coming air with your cheek, with your skin. Check for breathing should not last longer than 10 seconds. So it's better to count these seconds allowed, just not to lose the count, not to waste additional time. You are counting up to 10 while checking for breathing, and if there is no breathing or you are in doubts, you should proceed to the next step. You should never continue if you are in doubts. It will be better if you will start CPR even in patient who is still not in cardiac arrest than if you will delay life-saving actions when someone is in need, when cardiac arrest is there. After checking for breathing, and if there is no breathing, we can improve our diagnosis, support our diagnosis by pulse check. For adults, we are to check pulse on carotid artery, for little children, for infants on brachial artery. Carotid artery is located medial to the sternocleidomastoid muscle on the level of, and we are to palpate on the level of thyroid cartilage. While checking for pulse, you should keep head extended, still airways open. So one of your hands is still on the forehead, supporting head in extended position, while another hand is checking for pulse. Pulse check again should not last longer than 10 seconds. And again, if you're in doubts, if there is pulse or there is no pulse, you should commence CPR. You should not delay. So that the whole procedure of the recognition of cardiac arrest should not take longer than 20 seconds to half a minute. If the victim presents with no consciousness, unresponsiveness, no breathing, or maybe agonal breathing, that is equal to no breathing. Agonal is occasional gasps with open mouth with use of accessory muscles. It's called gasping as well. So agonal breathing is some kind of residual breathing that stops early after cardiac arrest. So if you are seeing agonal breathing, you should make the same conclusion as in no breathing. Agonal or no breathing means cardiac arrest. So unresponsive, not breathing or not breathing normally, and pulseless means this person, this victim is in cardiac arrest. And we should immediately call for help if not done before. Call for help means that you should ask some of the bystanders to help. You are showing to a specific person with your hand and telling this person to call emergency number. You should pronounce this emergency number like 112 or 103, depends on your location. And you are asking this person to report to the EMS dispatcher that there is someone in cardiac arrest and you are starting cardiopulmonary resuscitation. You should not report any additional information at this step because the rest of information needed, like address or age of the victim, will be requested by dispatcher themselves. Your task is to start CPR as early as possible, so you are providing minimum of information to the bystander, and this bystander next conversates with dispatcher. Another thing that you should request from someone from bystanders is to bring Aed device shown on this slide. Aed is automated external defibrillator. It is available usually in those regions of the world where specific public access defibrillation programs exist. It is about developing countries of the world. There, the Aed devices are located in public places where anyone can take this device, bring to the victim, prepare for use, and apply electrical shock to the victim. And this significantly improves survival rates. So if you are acting in the optimal environment where public access defibrillation program exists, you are asking another bystander to bring this device to the place of accident. If you are alone and there is no one nearby, you should not leave the victim in order to call for help or to bring Aed. You should proceed with CPR. What you can do practically is to use your own phone with loudspeaker function to call EMS and conversate with dispatcher, not delaying cardiopulmonary resuscitation. The immediate first step of basic life support complex, the most important part of basic life support is chest compressions. The chest compression procedure is emphasized in the guidelines. It is highlighted that without chest compressions there is absolutely no chance for survival, while without breathing, without rescue breathing, it is still possible because chest compressions do provide minimal ventilation when it works like a chest pump. If we are thinking about airways, and if airways of the victim are open, when we are compressing the chest, we're increasing intrathoracic pressure and pushing blood contained in heart and big vessels to the circulation. But when we are decompressing the chest expands, and this creates negative pressure, and this negative pressure may draw some air from environment to respiratory compartment of lungs. So if the bystander who provides care is untrained, unable, or not willing to provide rescue breathing, they are currently recommended to proceed with chest compression only cardiopulmonary resuscitation when they give chest compressions continuously without interruption up to arrival of EMS to the place where victim is located. How to do chest compressions properly? Please look at the photo where this lady is showing proper position. First of all, your hand should be located in the center of the chest. More precisely, it should be located on the lower half of the sternum, strictly on the midline. You should not shift your hand to the right or to the left, strictly on the midline. Your arms should be completely straight, both during compression and decompression phase. There should be no flexion in elbows of your arms, because you are using your straight arms as, we can say, guide wires to apply force that is created by your upper body weight. The correct technique of compressions is when the rescuer is utilizing not muscles of upper extremities, but their upper body weight. So you should lean over the victim. Your shoulders should be located above the victim's chest, and you have to press to the chest hard for about 5 to 6 centimeters in depth, at least 5 centimeters, to produce effective compression of the chest. After every compression, you should allow for complete recoil of the chest. The chest should expand completely. Remember that during expansion, during recoil of the chest, the blood is attracted to the heart for subsequent compression. If you will not allow for complete recoil of the chest after the compression, if you will press somewhere in depth continuously, but will not allow for big amplitude of your movements, the ejection from heart will be insufficient. Another important parameter of chest compressions is rate of compressions that is recommended to be continuously supported in the range of 100 to 120 compressions per minute. It's quite fast. 120 is 2 compressions per second. So this rate should be adhered strictly to produce effective compressions. And another parameter is compression to ventilation ratio, that is to be 30 to 2. After every 30 continuous compressions, you are making a short pause to give 2 rescue breaths. You should minimize all interruptions. Like for rescue breathing, when you are making a pause in compressions, it should not take longer than 10 seconds to change your position and to give 2 breaths and to resume chest compressions. The total duration of pause in compressions for rescue breathing, for giving these 2 breaths, should not exceed 10 seconds. And every 2 minutes, you should rotate the person who compresses the chest, if possible. If there is someone nearby who is trained, you should interchange your roles every 2 minutes. For example, one person gives chest compressions for 2 minutes, while second rescuer is giving breathing. They are working with a ratio of 30 to 2. After 2 minutes, after several cycles, they should switch their roles, and now first person will give rescue breathing and second rescuer will commence chest compression procedure. How to give rescue breathing? There are 2 steps for rescue breathing provision. First, again, you should open airways, as we did in the first initial step of assessment. You are performing head tilt, chin lift, and while holding head in tilted position and chin lifted, you are to apply your mouth over mouth of the victim. You should achieve airtight sealing and give breath. One breath is 1 second long, As for the volume of breath, it should be minimal to produce visible chest rising. You should never overinflate the chest, because overinflation of the chest produces the risk of inflation of stomach and regurgitation with subsequent aspiration of gastric contents. Also, overinflation of chest increases the risk of barotrauma. While you are breathing in, while you are giving this breath, you should simultaneously look at the chest. As soon as you will see the chest is rising, you should stop the breath. You are making short interruption, you are withdrawing your lips from victims. Passive exhalation happens, and immediately you are giving second breath in the same way as first. After second breath, you are to get back to the chest compression procedure. Automated external defibrillation. If AED, automated external defibrillator, is available, it should be brought to the place of accident, and the person who brought the device should prepare it for use. Optimally, you should not stop CPR to do it yourself. The device should be prepared by someone who is free of the main BLS actions. So you are continuing with chest compressions and rescue breathing while your assistant is opening the bag with device, turning the device on, and starting to follow commands of this device. The Aed devices are designed specifically for use by bystanders, by people with minimal to no training. So these devices are very simple in their use, and when you are turning the device on, it starts to give you voice prompts. It tells you what to do and how to do. Usually, one of the first commands of the device is to take electrodes, which are shown on this picture, which are single-use and adhesive, and to place these electrodes on the chest. Usually, the position for electrodes on the chest is shown specifically on the electrodes. So you will do just like it is shown on the electrode, but generally the position is the same, irrespectively of the model of the Aed. One electrode is placed on the right, just under the clavicle, and second electrode is placed on the left side of the chest, approximately on the level of fifth intercostal space, along anterior axillary line. After electrodes are applied and connected to the Aed device, the device will tell you to stop cardiopulmonary resuscitation and not to touch the victim anymore, because now the device starts to analyze the rhythm. It will analyze the ECG. It will not show you ECG. There is even no monitor on the Aed device usually. But by using its intrinsic algorithm, it will analyze the ECG and determine if the electrical shock is needed. If shock is not needed, the device will tell you in words, please continue chest compressions, and it will probably also start metronome that will give you audio prompt as for proper rate of chest compressions from 100 to 120 per minute. But if device will determine that the ECG is ventricular fibrillation or pulses ventricular tachycardia, which are shockable, it will tell you to push the button to release shock. Using safety precautions, not touching the victim or any metal objects which are in contact with victim's body, you should push this button. It will release the shock, and immediately after defibrillation, you should resume chest compressions with all previously mentioned parameters, with depth of 5 to 6, a rate of 100 to 120, a ratio of 30 to 2, with rescue breathing. After 2 minutes, the automated external defibrillator will repeat the rhythm analysis. It will again tell you to stop. It will analyze the rhythm, and if needed, again will recommend you to push the button to release shock. And it will reproduce and repeat this analysis every 2 minutes throughout the duration of cardiopulmonary resuscitation attempt. The rule is that after electrical defibrillation, you should never try to check for vital signs. Yes, it's possible that electrical shock will resume normal cardiac activity, will resume normal sinus rhythm. However, even if defibrillation will cause a return of normal cardiac rhythm, it will take some time for heart to regain its contractility. For the first few minutes, first 3 to 4 minutes, heart is still very weak, so it needs support to provide adequate blood flow throughout the body. That's why you are to continue chest compressions. The general rule for chest compressions and for rescue breathing, generally for BLS complex, is to continue till arrival of ambulance team, till EMS arrival, or till appearance of signs of recovery for the victim. Signs of recovery should be obvious, should be visible. The main sign of return of spontaneous circulation is a return of normal breathing. If you are seeing during the CPR that person starts to breathe, you should check if the breathing is normal. You should check for additional signs like responsiveness. Patient may start to open eyes, may start coughing, may start moving extremities, but the most reliable sign of return of life is normal breathing. So if breathing normally, you should stay with the victim, optimally provide him a left or right-sided recovery position, because in sided position there is less risk of airway obstruction and of aspiration, and you should wait for arrival of EMS, continuously, closely monitoring vital signs. If you will see that patient again stopped breathing, you should immediately resume CPR. It frequently happens that cardiac arrest is recurrent, so you should expect for this possibility and you should account this risk. For children, there are some specifics, some peculiarities of basic life support cardiopulmonary resuscitation. The main difference is that for resuscitation in children, we are recommended to start not from chest compressions, but from rescue breathing. We should give 5 consecutive rescue breaths from the beginning, just after confirming cardiac arrest and calling for help. And then we are continuing with compressions and ventilations in the ratio of 15 to 2. The explanation for this difference is that in children, usually cardiac arrest happens due to secondary extracardiac reasons, usually due to respiratory distress, due to very severe hypoxia, like in severe bronchospasm, laryngospasm, or foreign body airway obstruction, or drowning. In these cases, we should address this problem by first taking oxygen from environment, moving it to lungs, and only then by compressions. So first we are giving 5 consecutive rescue breaths, and then we are continuing with compression to ventilation, 15 to 2. Again, this difference in the ratio compared with 30 to 2 in adults is because we should increase the number of breaths compared to the number of compressions to account for the deficit of oxygen in the body of the child. One more difference is regarding the technique of chest compressions. In infants, as you can see on the left picture, it is recommended to use 2 thumbs, or alternatively, we can use index and middle fingers of one hand to compress the chest. In children older than 1 year but below 8, we are recommended to use one hand for chest compressions, just like it is shown on the right slide, on the right picture. In children older than 8, we are recommended to use both hands, same as in adults. Depth of chest compressions is a bit lower. In adults, I remind you, it is 5 to 6 centimeters. In children, it is about 1/3 of anterior-posterior distance of the chest. That is about 4 to 5 centimeters. This is it for theoretical part. Please think about questions, and if there are any questions, please write them in chat. And now I want to show you one video, short video produced by European Resuscitation Council that is showing the imitation simulation of cardiac arrest case, and it shows how to properly perform the algorithm of basic life support.
Are you alright? Are you alright? Call 112. Unresponsive and not breathing victim. I start CPR. Get me an Aed.
Hello, I'm with an unresponsive person. He's not breathing. We started CPR.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30.
Apply pad to patient's bare chest. Plug in pad connector next to flashing light. Apply pads. Plug in connector. Analyzing heart rhythm. Do not touch the patient.
Stand clear.
Shock advised. Charging. Stay clear of patient.
Everybody stand clear.
Deliver shock now. Press the orange button.
Shock.
Shock delivered.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7. Everybody stand clear.